missing tooth, we'll just compare and see. And we'll see for indications for implants, then some advantages, then some different, I'll speak on case selection and some types of different implantations we can have, and prosthetic option. We are going to discuss on a bit of occlusion there, and case presentations, finally conclusion. Now, I feel implants are amazing because they integrate with the bone and they work in the oral cavity. So osseointegration, all of you understand that it's a phenomenon where a titanium integrates with the osseous tissue of the human body, and that provides a foundation for building our prosthesis. Now, implants are successful because of osseointegration, and many researchers say still osseointegration, is a mystery. But different theories have come out where we think, osseointegration happens through a proper biological sequence. But just to understand in a simplistic way, osseointegration is nothing but the bone growth over the titanium, and the gap is less than 100 microns on a light microscopic level. That's when, we say osseointegration is achieved. Now let's come to this topic when we have a situation of missing posterior tooth. So in one of the study, especially in India, it was told that at least 20% of Indian population have at least one missing tooth. And we know that first molar is the first permanent tooth to erupt, in the oral cavity at the age of around 6 years. So that's the tooth which is also subjected, for decay or any other disease, and it's the tooth which is more susceptible for loss. So it's in our practices we quite often see the first molar or the second molar or the posterior teeth in general are missing, and that poses a lot of problem, especially for occlusion and function, then supra-eruption of the opposing teeth and things like that. So in this radiograph, you can have there is a first molar missing in the fourth quadrant and second molar missing in the third quadrant, and especially on the third quadrant where second molar is missing, implant is the solution just to replace the tooth, just to prevent the supra-eruption of that upper molar, which is trying to come down. I'm trying to change the slide, it's just stuck. Yeah. So we try and place a largest implant possible with the available bone there, and we try to restore the tooth. And you can have a closer look here. So we make sure implant is away from the natural tooth, at least 2 to 3 millimeters, and also away from the any vital structures. Like you can see at the bottom, it's away at least 3 millimeters from ID canal, and also intraocclusally, you have sufficient space, at least 7 to 8 millimeters for a molar to replace and give a good height for the crown. And once we place it, we wait for 3 months at least to integrate. We get a good soft tissue profile. That's when we are going to restore the tooth. So we are going to do our prosthetics and place a PFM crown, and we are going to restore the whole situation. Now you see this case. The implant was placed in 2005 and 12 years of post-op. It's 2017. Now it's almost 2020. It's been 15 years for this case, which was done, and still it's working. And I think all of you will feel happy to know that this patient is none other than Dr. Abid, who's also a GDP member, who had received implant for his missing tooth in 2005 from me, and it is still working. It's been 15 years, and you can see a bone loss there after 12 years, which is around 2 to 3 millimeters. And normally we say 1 millimeter of bone loss is evident after first year of loading. and 0.2 millimeter bone loss every year will happen, which is considered as normal bone loss or resorption. So there is a bit of bone loss over the period of years, but still 80% of the implant is submerged in the bone and it is functional. So this treatment modality, in my experience for this particular case, is highly successful. Now we'll come to the treatment numbers. This data is very important as clinicians for us, how the implant practice is developing. So in this research, we are trying to compare the endodontic treatments done annually compared to and with that of implants. So you can see there was a small research from the Millennium Group which has shown the endodontic treatment, which estimated for the year of 2000 were around 30 million endodontic procedures annually from ADA, whereas you can see the number of implants, like in 1996, it was somewhere around 300,000 to 400,000. And in the year 2000, which increased threefolds, that went to around 900,000, that's around 9 lakh. And in 2010, it went up to 2 billion. See the exponential growth there. That means the treatment modality of replacing tooth with an implant is really, really increasing. A lot of dentists are adopting this treatment modality. So this science is growing. So in 2010, they said the future growth will be around 18.6% annually. So that's how, in 2020, we see a lot of dentists are considering implants, for treating the missing teeth. So in this graph, we can see the number of patients versus number of implants placed. So annually, year by year, we can see the growth in terms of number of patients and also number of implants, which have been growing annually. So consider this case, single, missing tooth in the posterior region. So what are the treatment options we have? We have around 5 different treatment options. I think all of you can, name few if you have in your mind. So we have removable partial denture, a very, very simple traditional treatment, a flipper we can put. Fixed partial denture, a 3-year fixed partial denture is a conventional treatment approach, which many of us think of. Implant prosthesis we can plan. You can have a resin bonded prosthesis in some cases. And also if you don't want to do anything and maintain the space, if there is a active orthodontic treatment or due to some other condition, you can definitely have a space maintained. So there is, when we compare the treatment modalities and when I ask each of you what will be your preference, each of you will give different treatment plans. So in dentistry, say no two dentists will think similar for a particular case, because we have different treatment plans, and trust me, everything works. We know that mouth is a forgiving organ in the human body. So whatever treatment plan we do, it works for a different timeline. So when we are planning for a treatment for a particular condition, or especially for a single tooth replacement, we have a good option of fixed partial denture. We have a single tooth implant. These are the 2 popular treatment modalities which we can compare, and these are the 2 big competitors which we have to look into for any particular single tooth replacement case. So we have some advantages, some disadvantages. Let's see in the research how it goes. So when we do a fixed partial denture and we look at after 10 years, the literature says 50% survival rate is evident. That means out of 100 FPDs you do, maybe 50% will survive, definitely for sure. Then when you compare the single tooth implant, the success rate goes up to 97% for about 10 years. Then caries is the most common cause of fixed partial denture. They say around 60% of fixed partial dentures, fail due to the caries of the abutment teeth, and another 30% goes because of the periodontal problems. Whereas there is no risk of caries when you compare the implants, except there is a chances of teeth getting decayed for adjacent teeth, but that also can be managed because it's visible. Then 50% of FPD abutments, they require endodontics. In this case, it's not that case. Failure of abutment teeth of fixed partial denture is around 8% to 12% at 10 years and increases to 30% at 15 years. So eventually your fixed partial dentures will fail because if the abutment teeth will fail because of the caries of periodontal problems. And those of who are practicing from last 10 years, 15 years, 20 years, and you can see your patients coming back to you, at least few of the patients coming back to you, where you must have noticed the decay of the abutment teeth, or there is a periodontal problem and things like that, and eventually they are losing their old prosthesis. We'll end up in expanding the span of the fixed partial denture, or we can consider even implants in such cases. So that's how it is. So they say as we practice more number of years, we see more failures because the patients we treat, they tend to come back to us, and that's how it is. Then 80% of teeth adjacent to missing teeth have no or minimal restoration uh, in the case of fixed partial dentures, whereas in implants, it's much reduced. So there is improved aesthetics of adjacent teeth, there is decreased cold or contact sensitivity of adjacent teeth, and there is a psychological advantage definitely, and also decreased abutment tooth loss. These are few things which we can point out in the literature. So in the nutshell, we can just say about three things. That fixed partial dentures, there are advantages and there are disadvantages. And if you see the disadvantages in fixed partial dentures, the biggest disadvantage being significant reduction in the amount of tooth structure which is necessary, whereas in implant you're not going to touch your adjacent teeth. That's the biggest gain. And long-term survival, we just saw the literature. With the fixed partial denture, it's around say 87% at 10 years, 69% at 15 years, whereas the long-term survival with single tooth implants is almost more than 95%, more than 10 years. Then only disadvantage with the implants is it's more expensive compared to the fixed partial denture. But in today's world of practice, I don't think so, because I practice right now in UAE, Dubai. So here, what happens when I look at the cost, we do charge around, say around 1,200 dirhams or 1,500 dirhams for per unit for a crown, and 3 unit will come up to around 4,000 dirhams, whereas we are doing implants here for around 5,000 dirhams. So it's almost the same. And if the abutment teeth need endodontics, some cases we'll end up doing the endodontics. So the cost will really go up. So about the cost, I don't think so there's much of the difference. Even in India, in Bangalore, when I was practicing, the cost is almost coming up to the same. It's like, it again depends on the what type of implants and things you are using. But around, we used to charge around 20 to 25,000, and at the higher level we used to charge around 40,000 if you're using a implant of a better company. So the cost, I don't think so at this present times. It is not much, but again, it depends on the individual clinician how they are costing, and their clinic setup and their treatment cost. Next, we'll come into the contraindication for a posterior single tooth implant versus indication for a posterior 3-unit fixed partial denture. There are some contraindications. Again, we are going to do a small risk assessment before we go into the cases. So we have some local contraindications. So the contraindication for dental implants is like if you have an inadequate bone volume, like faciopalatal, if you have less than 5 millimeters, or mesiodistal less than 6 millimeters, then moderate to advanced mobility of two or more adjacent teeth, and then limited time for the patient. So we can't do implant treatment in such cases. Whereas indications for posterior 3-unit fixed partial dentures are if there is an inadequate bone volume, inadequate intra-tooth space, which is less than around 6.5 millimeters, lack of intra-tooth bone height, that's adjacent teeth are mobile or reduced time for treatment and things like that. So dentists are considering implants because a lot of patients are well informed today. They come and they study about implants and they come ask for the dental implants. Then there is a high success rate, we know it. There is a progressive development of new dental implant systems, diagnostic procedures, and introduction of some novel surgical techniques. Then there are advantages of technical procedures. CAD/CAM is there today, present today. You can prepare your surgery guides. You can have guided surgeries. And there are many training courses which are offered by universities, professional societies, and implant manufacturers. You can go and train yourself. And finally, it is profitable. We think we can charge a bit more for implant cases compared to FPD cases, and definitely it is profitable for practice. Now, let's go into the posterior single missing tooth in particular. So, till now, anybody have any questions or any doubt, Dr. Ali? I'm clear. Hello.
Yes, so far we haven't had any questions. Everyone's fine. Carry on, carry on.
Okay. So we are going to have a small treatment guideline and also a risk assessment. So whenever we are taking up a case for single tooth replacement, I think these are the 4 criteria which was given by ITR treatment guide, where we are going to assess the risk. So first, patient selection. So whenever we select a patient, definitely please get into the details of the medical and dental history, the risk which are involved, and also look into the anatomical risk factors in the radiographs or in the investigations you do. So when we come into the medical history of the patient, and there is a ASA guideline, which is Association Society of Anesthesiologists, American Society of Anesthesiologists Society. So they have a definite guideline where they classify into 6 types, ASA 1 to ASA 6. ASA 1, we know that the patient is normal, they don't have any asymptomatic, like for example, they can claim the stairs for the flight, and also they can move around in the malls without any exertion. Whereas ASA2 are the patients who have 1 or 2 medical conditions, but they are under control. Still, they can walk around normally. They can climb stairs. But the only thing with them is they are on medication for 1 or 2 medical problems. So such patients we have to look into, whether they have the previous medical history or their present medical condition is not a problem to doing the treatment. So category 1 and 2 is easy. The problem comes with ASA3 patients who have more than 2 medical conditions and which are not controlled. For example, uncontrolled diabetics. So they pose a big risk for doing the dental implants. So you have to consult them to the physician and make sure they don't have any potential problems for doing your implant surgeries. So again, as we go into the other classification, the problems get more worst, so we can't take up such cases. So biomaterials, definitely you have to look into a better product. So the implant manufacturing whole technology has changed. Earlier we used to get the machined implants, the surface treatments were different. Now we get a better surfaces, so better surface treatment. So look into what type of surfaces your implant you're going to use has, and see the literature and see the success rate of it, and see the whole company. So what I can say, when we look into different implant systems, around only 8 to 10% of implant systems are original, but rest 90% systems are clones of these 8 to 10 original systems. They have just copied and made 1 or 2 changes, and they have doing marketing. So just don't get into any system which comes into the market or in your particular region you're practicing, go into the system and look into the history and look into the product, look into the surface treatment and assess the condition and decide. Oh, my son is next. Treatment approach. Difficulty in documentation. So make sure you see how difficulty it is to perform the implant treatment in your practice. You have all the armamentarium. So make sure you just do this. I'm sorry, my son is in trouble. Okay, I'll come back to the presentation. So difficulty, just make sure how difficult it is to carry out the implant treatment. You have your complete armamentarium, you have a staff who are trained to assist you, and documentation is very important. So medical legal cases and medical legal issues are coming up everywhere. So make sure you document it properly and keep everything in order. And finally, clinicians. So you should have expertise. You should gain the skills to understand and perform the implant treatment, starting from your surgical protocol till you finish your prosthetics. And finally, judgment. You should have a good ability of judgment to change your treatment if you see any changes, or if you see any untoward, or you have to do uh, any minor changes while doing the surgery or while doing the prosthetics. Okay, Dr. Ali, I'll just give a pause. Is it okay?
Wait. My meeting was
Yeah, you can take a pause. It's fine.
Doctor, is it going fine?
It's going fine so far. Yes, thank you.
Okay.
You can proceed.
Can I continue, or do you have any questions?
Please continue. We haven't had any questions yet in the chat room, but once we get any questions, we'll let you know.
Okay, now we'll quickly get into this case. You can see a case here where we have one side 3-unit fixed partial denture, which is already done for endodontically treated teeth, and the other side you have a single missing tooth. So in the third quadrant, when you look at it, so you can see there's a missing tooth, and definitely any clinician will probably tell the patient that there's a good option for doing a single tooth implant there instead of reducing the second premolar and the second molar. So let's go into how we are going to plan this treatment and how much of bone is available. So we take a clinical picture. We see there is a good amount of mesiodistal space available for the crown, and also intraocclusal clearance is good to place a crown. So what we can do, we can just make a study cast and just put it in the occlusion and check. Then what we can do a simple diagnostic wax up, just place a crown with the wax and see in the occlusion whether that fits. Yes, it's fitting nicely. So we are going to do a putty index there. So with this putty index, we are going to mix a bit of auto polymerizing acrylic resin, and we are going to put a small ball bearing, which we think is a probable position of our implant at the center of the ridge, and we are going to prepare a surgical stent, or at this stage it's called radiographic stent, or you can also call as dual purpose stent, a radiographic and surgical stent. So this radiographic stent we can use, you can make a OPG of it, and you can see a ball bearing there, and this ball bearing will give you a clue that you can calculate the actual length of bone which is available there. So you can calculate like your Clark's formula for determining your working length. So the radiographic width of the ball bearing, actual width of the ball bearing, radiographic length of the available bone, and actual length of the available bone will give you a height of the available bone. In this case, it is shown around 16 millimeters by doing that. And length of the edentulous span, you can measure it from the distal aspect of the second premolar to the mesial aspect of the second molar. and you'll get a length of edentulous span. Then width of the available bone we determine by a technique called bone sounding or bone mapping. You can take a probe, put an endodontic plugger, a stopper, and you can put a surface anesthesia and check the bone. So we get around 8 millimeters at the crest and 10 millimeter below the crest at 3 millimeters in this case. So these are called cast-based method of determining the length, width, and also the height of the available bone. But nowadays it's more easier to get a denta scan or a CBCT where easily you can see or visualize the bone in 3 dimensions. So in this case we got around 16 millimeters in cast-based method, which I just said. In the denta scan showing around 16.6, then we have width of 9 at crest and around 12.7 at somewhere at 4 mm or 5 mm below the crest. So there is a good amount of bone in this case, and definitely we can consider this particular case for a dental implant. So radiographic stent which you made can be converted into a surgical stent by removing the ball bearing and can be used while doing the surgery as a point of entry for your implant. So before we get into the actual cases, there is a CYBERS classification for rich defects which can be applied. So we need to understand this very well, that after extraction there'll be a bit amount of resorption and there'll be certain amount of rich defect. So we lose the bone. So there is nothing called ideal case anywhere. So we have some defects. So class 1 defects are generally facial-lingual loss of tissue with normal ridge height. So most of the cases we get are either class 1 or class 2. So class 1 there is a good amount of height, but width will not be there. So class 2 where we have a loss of height of the ridge but width is maintained, whereas class 3 they'll have a combination like loss of width and height both. So in my personal experience, what I see is whenever I have a class 1 defect where height is good, width is less. So whenever I'm doing surgery, I just go and open up the flaps and look into the width of the bone, how much it is there, and then I'm going to place the implants. And these class 2 defects, especially in molar areas where width is good, and if there is a sufficient amount of height above the ID canal, then you can go ahead and even sometimes do a flapless surgery also, because you have a good width and if you have acceptable height of the bone. Then class 3 defects, yes, they are a little complex, so you have to be very careful. You have to do some special techniques, maybe called ridge plate or bone grafts or something like that. So they are the difficult cases which will pose a problem. Now, types of implantation. So we have 3 types of implantation when we consider placing dental implants. We can do immediately, we can do immediate delay, that is after extraction we can wait for 4 to 6 weeks for initial bone to form, then we can do implantation, that is immediate delay. And finally we can do a standard procedure, delayed implantation, that's at least 3 months after the extraction. We allow the bone to form, we allow the mature bone to grow, and we go ahead and do the implantation. So this case is a case of delayed implantation. So in this case, you can see in this video there is a missing molar tooth there. So we are going to do a standard technique. It's a ridge type 1 defect of the ridge where height is good, the width is less. So we are going to open up and see the amount of bone which is available, then put an implant and submerge it completely, leave it for 3 months to heal nicely. Because the width was less, we went for around 3.7, but height was good, so almost 13 mm utilized. Then we wait for the tissues to heal, then we open it up, do the second stage, make a good gingival profile, then place an abutment there, do the impressions, then our crown is ready, the PFM crown, and we are going to cement it. And this is the final outcome. So this is about a delayed implantation. So next we are going to do a flapless. If we have a type 2 defect, like we don't have height of the bone, but we have a good width of the bone. In this case, you can see there is a good amount of width of the bone, but there is no height. Sometimes we can pick these cases if they are ideal to do such flapless and keyhole surgery. So in this case, you can see a flapless implant we are trying to place, because in this radiograph, height of the bone is acceptable. There is a good width of the bone. So it's around 5.2 implant we planned, because the width is around 10 mm. So we are going to just give local anesthesia, then put a paralleling pin and check this paralleling pin whether you're going right, and then place your implant there. So it's a 5.2 millimeter implant, quite a wide implant there, and make sure your flat surface come on the buccal side so that it will help you during your prosthetics. So there is a good amount of healing with this single stage. So that's the paralleling pin. The implant is placed. It's well away from the ID canal, from the adjacent teeth, and after 3 months, you're going to take it up for your prosthetics. Trying to go to the next slide. Yeah. Now we'll go into the next step, the immediate delayed implantation. You can see in this case, there is extracted tooth, the first molar, and the sockets are still healing. It's around 4 weeks after the extraction. So we are going to plan an implant there. So there is a soft tissue, soft bone, which is just forming there. So we utilize the interdental septum, the interdental bone between the two sockets. So ideally our implant has to go in this position. So we open it up, we look into it, we remove all the tissue tags if they are there, then put a paralleling pin and check whether it's going in the right intended direction we want to place the implant. So implant is placed there, and we have sutured it back and leave it for healing, and 3 months later it heals up like this. Then we're going to do a gingirectomy there, and it's ready for the impression now, and we're going to make the impression, and a close tray impression is made. Then we have our abutment trial there, a milled abutment which is being placed, and we are having a crown now. So this is for a immediate delayed implantation, where we are going to utilize a bit of soft bone and place an implant instead of going for conventional surgery after 3 months. So this is the post-op. So now you can see in the post-op, it's much of healed tissues. So now when we consider immediate implantation for multi-rooted teeth, if you want to extract the tooth and put an implant immediately, then we have around 3 different situations. We call it as like the first situation, or a type A situation, where you extract the tooth, multi-rooted tooth, but you see a good interdental septum, you have a good amount of bone, then you can exactly place at the septum and utilize all the bone. And in the type A, you throughout 360 degree, the implant will be covered by a bone. So generally you can place around 4 mm or 5 mm of the implant, so that implant is completely submerged in the bone. In the type 2 or a B type, you can see in the second picture where the implant goes there, but a bit of implant is exposed into the sockets. So still, if you have outer walls intact, then you can just leave it there or put a small particulate graft, because blood clot is going to form there, and eventually it's going to heal up. So this is the type 2. In the type 3, you can see where you have a more of fused type of root, and you can put a very big implant there, utilizing completely. So the implant surface will engage the outer surface of the socket, and in these cases we put an implant of around 7 to 8 millimeter width, so that we engage the whole socket. So this is how we engage in this type of situation. So we have 3 different situations for immediate implantation of multi-rooted teeth. So I'm not a big fan of doing immediate implantation for multi-rooted teeth immediately, because it poses a lot of problem, especially if you have maxillary teeth which wide roots with thin septum and big sockets. Your success rate will come down, and also skills, your additional skills, your additional armamentarium, then having the bone graft, then sometimes having the risk of getting into the sinus perforations and things like that. So if you want to be safe, better, we can try immediate delayed, maybe after 1 month, or you can go for a conventional delayed implantation type of procedure. So second premolar, in this case, we have then the immediate implantation. So second premolar, if you have a single rooted tooth, second premolars, it's very easy, especially in this case. You can see there is a failed endodontic uh, tooth root. So remove the tooth. Atraumatic extraction is the key in such cases. So once you remove the tooth, check the socket, see there is no infection, no soft tissue tags, remove everything, and you can place a wider implant. In this case, we have placed a 5.2 millimeter implant. So the implant goes in and sits in the socket well, then it will heal up. Then after 6 months in the maxilla, you can open it up, uncover it for your prosthetics. So the impression post you can put, do your impressions, and regularly conventional procedures can be followed just to place the crown there and close it. So sometimes we'll have cases where we have some multiple missing posterior teeth, where we have different type of scenarios. So we have to take up sometimes a delayed implant type of situation in one area and immediate implantation in some areas. Especially in this case, in the fourth quadrant, you can see failing fixed partial denture. There is a fixed partial denture having abutment tooth on the second premolar and the third molar. So once we remove this fixed partial denture, we are going to lose the second premolar. Then having a long span from a canine to the third molar, or from first premolar to the third molar, is a very long span. So definitely we can take up this case for implants, and we can restore this case. So in this case, on the third quadrant, we can do a delayed implantation. A single implant can go there to prevent the mesial migration, also the supra-eruption. So implant will go in there, a regular implant. So that's the paralleling pin which has been there, and you can see a 4.2 millimeter and 11.5 millimeter implant is there. Whereas on the right side, we need to remove the tooth. That's the second premolar. We need to extract it and do an immediate implantation there. And we have to add 2 more implants in the region of first molar and the second molar. This is the root with the fractured post there. So we are going to plan 3 implants there. So immediate implantation in the socket of the second premolar. Then we are going to put on implant in the molar, and in the second molar, 1 more implant. So a wider implant goes into the socket, and 2 regular implants go into the posterior aspect. So you can see 4.7, 4.2, 4.2, they have gone into 3 places. So this is after healing 3 months later. So you can take up for prosthetic. So we use impression post there and do an open tray impression technique. We are going to discuss the impressions, different impression techniques briefly after this. So we are going to do a prosthetics, nice healed implants there. Then we are going to put crowns there. So the access holes have been cemented, and we have our crowns in position, and all the teeth are replaced. I want to skip this. Yeah. Now, this is a very important case, which I wanted to just put it for a discussion here. So surgical placement versus prosthetic position. We say implant dentistry is prosthetically driven. So we need to plan, and then we have to execute. So prosthetic planning or a pre-prosthetic planning should come first. then the surgical intervention should go on. See this case. So there is a missing 2 molars in the fourth quadrant. That is the first and second molar. So we are going to put an implant there. So in this case, what happened? We have put an implant there. It's a freehand technique where we just open it up and take uh, medial position of both the teeth, and we are going to put an implant, thinking that this is the ideal position. So implant is placed there, and even in the radiograph you can see it's gone perfectly well. So any surgeon will think it's gone perfectly, even just to look prosthetically it looks fine in this picture. So the healing was there after 3 months and opened, and there was second stage surgery done. And see the prosthetics, when once you go into the prosthetic stage, the impression is done. And but when we made the crown, implant was distal to the crown and the access hole was distal, and see the radiograph. So there is a big mistake which has happened, where implant was between the two teeth, but it is not a right prosthetic position for the crown. In this case, the implant should have gone more mesially next to the second premolar, to be at the center of the crown.
Fayaz, sorry to interrupt, just a moment. Fayaz?
Yeah.
We've got 2 questions. The previous one which you showed, the failing 4-unit bridge.
Yeah.
The previous slides. Now we've got a question from Dr. Pasha, Dr. Abid Pasha, asking, instead of doing 3 implants and placing 3 crowns, could 2 implants be placed in a 3-unit bridge? The question, similar question asked by Nadeem Ahmed as well. So if you could clarify that, please, that'll be great. While we are talking, it'll be easier.
Actually, I'll clarify that. Actually, it's a great idea to put 2 implants and 3-unit fixed partial denture there. So in that case, I was telling, I personally chose to do 3 implants there because I had to remove a second premolar and do an immediate implantation there. So that's a bit of risk there. And also the distal part is okay. You can put on implant, but connecting again, the immediate implanted, doing the immediate implantation is a bit of risk. And if it fails, then again, I'll not have a backup. So I thought I'll do 3 implants there and do, try and over-engineer the, whole treatment. So I decided to go with 3 implants there. And when I spoke to patient and explained all these procedures, and insurance was covering for the patient, so everything was going, well. It was for a case of choosing 3 implants and going, be at lesser risk. Everything was going well in that case. So I chose to do that. But yes, 2 implants, 1 big implant in the socket, and 1 more implant distally and connecting with a fixed partial denture 3-unit is definitely the other option. It can be done. So the risk is little higher in that treatment protocol. So if you take the risk assessment, doing 3 implants is more easier or less risky. And definitely it's personally, you'd like to do more implants in a particular case and restore them. So that's how we can assess that case. I hope I answered that question. So I'll go ahead.
Yeah, you can proceed. Just to remind you about the time, Fayaz.
How much we have time?
About 5 more minutes.
Okay, I'll just try and finish it quickly. So now, very important, I have only 2 or 3 things to discuss. So impression making is very, very important. So when you do the impression, always use a rubber-based impression. So the best material to do impressions in prosthetics to reproduce anything is polyether, but the cost is very high. So at least we use addition silicone. And don't use silicone. Condensation silicone is still, I prefer it to use it only in the lab purpose, not for the mouth. So in this case, you can see we have made a closed tray impression with the addition silicone. That's heavy body goes into the tray and light body goes into the mouth, and we make an impression. So you can see the flat surface on the buccal side, and we have picked it up with a closed tray impression. So we make the closed tray impression and unscrew the prosthetic impression coping from the mouth, and we attach to the analog as shown in the third picture down there, and we put it to the impression with the analog there, and we are going to I'll just go to, yeah, and we are going to make a cast out of it. Make sure and tell your lab to put a gingival profile, the pink silicone which you put it, around the implant just to mimic your gingiva. Ask your lab to do that, and then make a crown. And there is access hole in this. I'm going to discuss with the screw with a cement retained crowns the advantages and disadvantages of each type. And finally, we have restored it. Now, when we have two implants, never ever use a closed tray. Always use an open tray. So because there will be angulation problem, whatever parallelism you try to achieve, but some mishap or angulation difference will be there between two implants, that will have a lot of problem when you do the prosthetics. So to get a good result prosthetically and get a good fit and make your lab work more easy, do a open tray technique. In this case, you can see custom tray is prepared. There is a window there, and again impression is injected, and we are going to pick it up with the closed tray. So you can see in the first picture the copings are there in the impression, and attach the analogs. You can see the impression surface, and also from the other side, and these two crowns are made and they have been cemented. So this is the open tray impression procedure. Now when we compare the screw versus cement, there is definitely some disadvantage with crown. With you have cement retained crown and versus screw. The cement retained, when we make a crown which mimics like our regular conventional crowns, which you do it for our endodontic teeth or on the natural teeth. Say cement retained crowns, they idealize occlusal contacts because the complete occlusal surface will be closed. They are good for aesthetic, especially in anteriors, and they have less risk for porcelain fracture. And biggest advantage is like its simplicity, because all of us are know how to do the cementation, then we know how to adjust the occlusion in such things, and familiarity is there, passivity is there, and things like that. Whereas in screw retained, we have limited interocclusal space. Means the advantage being, if you have a limited interocclusal space, you have to use a screw retained. You can't go for cement. We have around a yardstick of around 5 millimeters. If the interocclusal clearance is 5 millimeters, then we go for screw retained. We can't do cement there because we need a sufficient space for the abutment, then the cement, then the crown. So less than 5, we go for screw always. More than 5, that's where cement crown are indicated. An absence of cement under space,
Sorry,
that's a big advantage. Then
Dr. Fayaz?
retrievability. Yes.
Sorry to interrupt. We have one question from Dr. Khan. What kind of crown is suggestive, or it's occlusion based, cemented or screw retained crown? He's asking what is the.
I'm coming into that. I'm coming into that.
You're coming
at
to
the
that.
end of the slide.
Fine.
Yeah, I'm at the end of the slide. I'm going to tell that.
Oh,
So
brilliant.
retrievability is a good screw retained crown. So when they ask which is good, cement is good or screw retained good. See, when I started implant practicing way back in 2004 or 5, we started with the cement retained crowns. So we used to do cement retained crowns. So eventually, when the cases used to come back to us, like for example, small prosthetic screw loosening, we have to remove the crown and tighten the screw. So that's where we used to have a nightmare, whether implant is moving or a screw is moving, or we used to have a lot of problem. And if you especially do full mouth rehabs, and if you do cemented, it's a biggest nightmare to retrieve the whole process and cement it back. So on a long-term basis, for a maintenance, take a protocol, screw retained is the best thing you can have. And otherwise, if you talk ideally, if you talk prosthetically, you need to have a good prosthesis with passivity. You should have good aesthetic result. Then cement retained is the best. But I personally use SCR concept. That's called screw cement retained concept. So we involve in this screw also, cement also. So basically what we are going to do is we are going to make our abutment, milled abutment, and we are going to prepare a SCR crown. First, when you are doing a final prosthesis delivery, that time we are going to cement the prosthesis, but we are having a small access hole on the occlusal surface. So that is a screw opening channel. So that can be done with a small filling, especially in the posterior areas. This works well because aesthetics won't be that concern, and occlusion you can easily adjust. And trust me, retrievability will be so good. You can recall your patient every year and open it up and see the gingival tissues if they're inflamed and things like that. And in one study, 60% of peri-implantitis happened due to the excess cementation which was left and which was not removed, below the crowns. You can reduce the peri-implantitis because you can retrieve these prostheses and you can clean it up. You can keep your gingiva. So now the whole world, the attention of the whole implant studies is going into the peri-implantitis to understand how to prevent the peri-implantitis, the maintenance protocol, and things like that. So this is a big help. So go for the SCR concept, screw cement retain concept. That's what I personally like it. But still, there are many people who wants to use cement retained, and some strong believers of screw retained are there. So that's how it goes. And finally, I'll just skip this because we don't have time. Then finally, very important last point I want to tell is occlusion biomechanics, one of the much neglected topic. So whenever we put an implant, make sure you put it on the implant and the tooth on the long axis. Both should have a one single axis, so the force are dissipated along the long axis of the tooth. So we had a discussion that what type of occlusion should be given. So in the mesh, the implant protective occlusion is the big concept which was given earlier when we did our post-graduation. We used to strongly believe implant protective occlusion, which is a lingualized occlusion basically, where lingual cusp tips will touch the central fossa of the opposing tooth. That's a popular type of occlusion which we used to give, but eventually the things have changed now. Now we believe mutually protective occlusion is a better occlusion because we need to protect the other teeth also along with the occlusion we give. So mutually protective occlusion where you have a occlusion in the posterior aspect and we have a disocclusion in the anterior, and when we have a contact in the anterior, we'll have posterior disocclusion. So this will protect anterior and posterior teeth together, and it will protect mutually. So mutually protective occlusion is the concept. So some great implantologists feel that Mish gave the implant protective occlusion or lingual occlusion, which is like no more valid. So anyway, mutually protective occlusion is the concept which I personally believe, which is good for the implant occlusion. And make sure in the posterior area when you do your margins, keep it slightly supragingival or at least equigingival, so that you can have a good access for oral hygiene, and you can visualize it, and you will not have any soft tissue problems there. And again, as I said, if you have less intra space, make sure you go for a screw type of prosthesis where you have a crown and a small screw which you can fit it there. Make sure you check the occlusion, put a articulating paper which is around 30 microns, check for the contacts, make sure the contact is on the central fossa where exactly the implant is placed, so that vertical forces are dissipated vertically. And finally, the current trends is all about socket preservation, because we feel bone is the gold standard for doing implant treatment. So whenever you have extraction and there is a socket, definitely in some cases, if there is a defect on the wall or something, try to graft it and preserve the bone, because we
Sorry,
know that after
sorry to
extraction.
interrupt you. Fayaz, one more question. We've got, is zirconia crown an option if patient is very particular?
Yes, zirconia crown, we can do it. Personally, I'm a big fan of PFM crowns, but zirconia crown is definitely indicative, and a lot of zirconia crowns are used now, and definitely zirconia crowns can be used, but only if you have a zirconia abutment in zirconia crown, the integration or the whole assembly will go well. If you have metal or titanium abutment and on the zirconia crown, there are some small shortcomings are there, but we can discuss this later. But yes, zirconia crown are popularly used. Now we'll come into the socket preservation, which I was talking about. So so whenever we have an opportunity of preserving the socket, give an option to the patient and preserve the socket, because preserving the bone, the ridge contour is very, very important. So we can put an implant there. So we can put an implant there, and we can preserve the socket, and we can place a bone graft there. So regarding the membrane, if you can close your flaps completely, then you can put a resorbable membrane, or if you can't close your flaps completely, then put a non-resorbable membrane, just tuck in nicely into the flap and put a non-resorbable membrane. After 3 months, you can remove the membrane and put an implant. And socket grafting definitely will help. You can see in this case, which has preserved a lot of bone there, and definitely you can go ahead and place the implant there. So socket shield for posterior teeth, it's of limited use, but for anterior teeth, yes, the socket shields have a lot of advantage, where we leave a small lip of a tooth there and remove the other big part of the tooth from backside. It's called labial shield, or socket veneering. I think different names have been given. So that's about the socket shield. I'm not going into the details because of its limited use in the posterior region. So conclusion, single tooth implant is the most predictable and conservative method of tooth replacement with long-term success, say more than 96%. Use of removable prosthesis will limit the patient to recover normal function, aesthetics, and speech and comfort. And finally, implant-supported prosthesis allow the patient to function with confidence and enjoy better quality of life. With this, I am going to conclude the presentation and take up some question if anything's there.
Do you want a short break, Fayaz, before we start?
No, I don't want a short break. Maybe please start a panel discussion. I thank everyone. All of you stay safe. Thank you, Dr. Ali, Dr. Nadim, Dr. Nair, and all the GDP core group for giving this opportunity and organizing this webinar.
You're welcome. So people, what I would suggest is type your questions on the chat group, and then I can unmute you guys. If you would like to talk to the panel members, putting your questions forward, that would be great. Today we have 3 panel members. One is our speaker, Dr. Fayaz, and then we've got Professor Hilal and Shamas as well, and both of them, or all 3 of them, would be taking down your queries and doubts. Hope this was helpful. I'm going to start off with questions. So please questions forward in the chat group, and then we can I can unmute you all to ask those questions.
I think Dr. Fayaz can, off his screen sharing.
Yeah.
Brilliant. Come on, guys. You've got great panel members here.
Can we have the panel members' videos on, please?
You want me to unmute the panel members?
Yeah, unmute them and the videos as well.
Fine.
Thank you very much, Dr. Fayaz. That was a very comprehensive and a very a good presentation about the replacement of single posterior missing teeth. I have a small question. In your conclusion slide, the first sentence you said the replacement of single missing tooth, the success rate is 96%. When you say 96%, does it pertaining to immediate loading or delayed loading?
It's an overall percentage, but I feel with the immediate loading in the posterior region, the success rate is very less, and also it is not advised at all in most of the cases, I feel. So immediate loading is not a question. So immediate implantation we can take up, but immediate loading without function can do in some cases, but immediate loading with function is absolutely no in the posterior region. So the success rate which I have put is the overall success rate. For example, if I do around 2,000 cases in a year of in 5 years and do a follow-up for 2 years, then I have around 96 or 95% success rate. That's the cumulative success rate of meta-analysis of different studies. So it's not a success rate of immediate loading. The immediate loading success rate is very, very low.
Just a follow-up question to the response. I'm so sorry. I think I lost the flow.
Yeah.
We've got a question from Dr. Khurat here. I'm going to unmute Dr. Khurat so she can ask the question directly. Yeah.
Yeah.
Just give me.
Hello.
Oh,
Hello.
yes. Sorry, you could unmute yourself. Yeah, please.
Yes,
Please go
sir.
ahead.
So I wanted to ask, you said the socket shield technique, no, sir, where we are leaving the labial aspect of the tooth structure.
Yeah.
Okay. So I just wanted to know, sir, like how the osseointegration will differ, because in this, the implant will be touching the labial aspect of the tooth structure. So compared to that, in a normal implant, when we are placing, there is like all the four aspects are surrounded by the bone. So how is the osseointegration, so like compared to that of, socket shield technique? I wanted to know.
Yeah. See, we have something called BOI, bone implant, bone implant contact, BIO, I'm sorry. So more the bone implant contact is there, more of osseointegration. In socket shield, what happens, will not have any integration on the labial aspect with the tooth and the implant. So that 20 or 25% of the implant is not integrated. But the other biggest advantage with this technique is it is going to preserve your labial plate. So anterior area is aesthetically challenging, especially if you have a single missing central incisor. That's the most difficult aesthetic challenging case for implant dentistry to take up, because there will be a bit of labial plate which has been gone, the soft tissue must have gone up, and doing it, restoring it aesthetically is a big challenge. Once you preserve this socket shield, a bit of labial lip of tooth, so you can definitely go and place an implant. So you can have a good integration on the mesial, distal, and also sorry, not on the mesial, the distal and the other two aspects. So it will work. So studies have shown up, the socket shield really works, but only the biggest challenge in this is, bisecting the tooth. So you need to really take a good burr and separate the tooth and take out the tooth completely to the apical area, and also leave only a small shield. So it works like that.
Okay, sir. Thank you, sir.
Faz, again, regarding the follow-up question, when you say success is good, success rate is based on how many years? If an implant stays in the mouth for how long do you say it is a successful implant?
It's a very good question, Dr. Nair. So whenever we say the success of implant, for how many years? So see, minimally, we say a lot of studies are there, like for 5 years, 10 years, 15 years, or things like that. But implant to be a successful, there is something called early success, intermediate success, or a long success. So early success we say for 3 years, intermediate is around 5 to 8 years, and long success rate is above 15 years. So as we go more and more, the success rate definitely will come down. So early success is very high with 3 years. If it is around 99%, 98%, studies have shown it's good. Intermediate success rate is the what most of us will look into. So it is around 96 to 97%. And once we go more than 15 years, and following it up for 15 years is also very difficult, your cases. So that will further come down, maybe around 92, 91, and different aspects. Again, with the long success rate or following it up your long cases, the techniques would have changed, the treatment protocol would have changed. So it's really difficult, to evaluate and also to give a success rate. But intermediate success rate around, as I said, around 5 to 10 years is the time period which we can consider presently for this. So whenever I talk about success rate, it's around 5 to 10 years.
Thank you, Dr. Faz.
So Dr. Iftikhar's got a question. I've unmuted you, Dr. Iftikhar. You can ask directly.
Assalamualaikum, Fayaz.
Walaikum
I think Dr. Hilal's also there. You could
yeah.
send the
My
questions.
friend Dr. Hilal is there. He can answer.
See, the question is, in cases of maxillary posterior teeth, what are the maxillary sinus considerations are you going to do, especially when you're placing these implants? My particular point is for those patients who already have this maxillary sinusitis problem, Do you suggest implants for them, especially if there is some sinus lift to be done? What could be the effects of such kind of
Yes.
protocol?
Yes. Dr. Hilal would like to answer?
Yes, basically what we see in the maxillary sinus is the amount of bone what is available below the sinus. So basically when we have below bone around 5 mm, we can always use a direct approach or a lateral approach and lift the sinus, use the graft and place the implant. But in cases where you have very less bone, for an example, if there's 2 mm, 3 mm, we usually avoid placing implants. That is what I suggest everyone. So minimum of bone 5 mm, then you can always have an option of pushing the sinus up and placing the implant with the graft.
Now, if the patient already has a sinus problem. Yeah, sorry,
sinus we are not going to perforate. See,
no, not perforate. By lifting the sinus, by lifting the sinus, would it aggravate their sinus problem in case they are already a chronic sinusitis problem? Is there anything like that?
No. Usually it will not happen, Dr. Iftekhar, only unless until we perforate it and there is some problems, then we may have to take care of it. Otherwise, usually you push the sinus and carefully place the graft without perforation. I usually don't see any major problems, or you can always have there is no such problem as such with that.
Okay, Jazakallah.
Yeah, just to add that, I have 1 or 2 things to add. See, regarding the sinuses, the question is like, will it get, if they have previous history of sinusitis, it will get infected. See, if we are undertaking the implant treatment and you are playing with the sinus membrane and you, damage it and it will get infected because of your treatment, yes, definitely the sinusitis will get aggravated. But we always take a precaution not to, break the sinus lining. When you do that direct sinus lining, that's when, the chances of breakage is more, when the bone is less than 5 millimeters, as Dr. Hilal was suggesting. But more than 5 millimeters, say around 7 or 8 millimeters, and you're going to do an indirect sinus lift with the crystal approach, definitely there is absolutely no problem to go ahead and do an indirect sinus lift. But direct sinus lift with a lateral approach, or with a crystal approach, yes, there is a big risk that you can damage it, especially if you're not skillful to do it. So if you are doing initially starting up cases or first case or second case doing sinus lifts, in such cases I advise to avoid. Only if you're a skilled surgeon handling and you know how to handle the infection also, then only we can take up such cases. So risk is very high in such cases. So definitely there is a problem.
The next question is from Nadeem Ahmed, the different Nadeem. I've unmuted you, Nadeem. You could put forward your question.
Yeah, thank you. Assalamu alaikum, Dr. Fayaz. It's a very nice presentation. My question is, in which situation you would definitely give preference for zirconia crowns or PFM for implants? Are there any studies like where you, definitely it gives better advantages for zirconia?
Yeah,
sorry, let me interrupt. Once you put your question forward, can you please mute your mics and so everybody can hear properly? Thank you. Sorry, Fayaz, you can carry on.
Yeah, the biggest advantage with zirconia crowns is the aesthetics. So anteriorly, personally, I do a lot of zirconia crowns for anterior cases. But when it comes to posterior teeth, I prefer still PFM because they take up the occlusal stress as well. Even if there's a high point, there is a small fracture of ceramic, which will become very evident. If zirconia fractures, remember whole crown fractures. So you need to change the entire crown. But in PFM fractures, there is a chip of ceramic. You can always take out the crown and do the resurfacing and reglazing and put it back. Personally, I feel PFM crowns are easy to correct if something goes wrong. Zirconia crowns are difficult to correct. If they break completely. So that's how I feel. But zirconia crowns in anterior regions, aesthetics, it's really, really excellent. And again, I was talking about the doing a zirconia crowns on the titanium abutments. The interface is not that good. The metal to metal interface is better than zirconia to metal interface. So again, the prosthetic screw also, which goes through the zirconia crown, if you are doing a zirconia crown, again poses a bit of prosthetic challenge there because of the stresses generated there and leading to the zirconia fracture. So this is what my observation is. But I've seen some implants having implant body at the collar. They have made zirconia, collar for the implants itself, just to give a good aesthetics. But also that also didn't work well because of the stresses generated at the crest and fractures. So I personally feel zirconia crowns are good for aesthetics in non-functional area in the anterior, whereas in the posterior, still I am a lover of the old school PFM crown, so I still do that.
Right. The next.
Okay.
Sorry.
Just one second. Sorry.
Yeah.
I have this. For patients with bruxism and heavy bite, for those patients, even you will prefer PFM or zirconia posteriorly?
Yes, PFM will work better for bruxism because there is. First of all, if you have bruxism, we don't advise implants because they're going to fail because of the load, and off-axis load is very dangerous. But if there is heavy bite, heavy clenches are there, such cases are there. For such patients, yes, PFMs, I feel they work better. Zirconia, yes, there are many studies which can compare the metal PFM and things like that. There are definitely advantages, disadvantages. If you ask me, still personally, I feel gold crowns are the best of all the prostheses we do. We know that because of aesthetics, we can't use the gold crowns. They are the most biocompatible and biomechanically, they are the most, better material. But zirconia has definite advantage compared to the aesthetics. But with the newer zirconia coming up with good mechanical properties, they are coming up. But as I said, it's my personal understanding is that I want to use PFM in the posterior region. That works well for me.
Fayaz, just a moment. Can you, I just need to ask you a few things. Can you stop sharing your screen? The stop share button at the bottom. Can you click on that, please?
Yeah.
That's good. The second thing is, can we keep our responses short, please? Because we are running out of time. The next question is from Abid Bhai. I'll just unmute him so he can put the questions forward so that it's better. The speaker speaks to the. Sorry. Yeah, Abid Bhai, you can ask the question, please.
Assalamu alaikum. Can you hear me?
Yes.
Yeah. Dr. Abid.
Fayaz, just had a small question. If there is enough bone available, say like about 12 or 13 mm, can we place a shorter implant? Is going to be a problem about 8 to 10 mm?
A very good question, Dr. Abid. It's about short implants. See, as we need to understand the biomechanics, how implants work after you place for next few years. So what happens is we know that there is 1 mm of bone loss after you place an implant within 1 year, which is very, very evident. Then we say around minimally there is 0.1 or 0.2 mm bone loss every year. Imagine you have placed a 5 mm implant, and after 10 years, so you have additional 3 millimeter of bone loss or 2 millimeter of bone loss when you calculate 1 mm first year and 0.2 millimeter every year. So your short implant is going to be exposed at least 3 millimeters after 10 years. So it will have only 2 millimeters bone. So I can share an article where how the short implants will fail over a period of time. So there is also a study which says if you increase the implant length by 1 millimeter, the success rate, long-term success rate goes up by around 18%. For each 1 millimeter increase in length, 18% success rate goes up. So things like that. So as much as possible, try and utilize the bone and put a longer implants. What I understand personally is 10 millimeter implant is the minimum length which are used for long-term success. So I keep it in my practice. 10 millimeter is the minimum. So less than 10 millimeter, I don't prefer to place implants in such cases.
All right. Thank you, Fayaz.
Right. So the next question, we'll put it through to Dr. Hilal from Dr. Pasha. Azim Pasha is asking, implants, are they contraindicated in patients taking bisphosphonates for osteoporosis?
Yes, implants are relatively contraindicated in patients with those kind of drugs. Okay, so absolute contraindications in patients who are on chemotherapy, osteoradionecrosis. So it's always advisable to have the bone index done, evaluate it, take the cross reference from the specialist whom they are being treated, and then go ahead with the implants.
Assalamu alaikum. I have a question.
Sorry. Okay. Sorry, Dr. Hilal. One more thing. Is it this absolute contraindication? Is it for oral bisphosphonates or IV bisphosphonates? Dr. Hilal?
I'm not good in that. I'm not sure of it. I think Fayaz can tell me it's better.
Yeah. See, regarding the bisphosphonates, there are different studies have shown up. One study which I came across and which was discussing in the other webinars which I was going through. See, oral bisphosphonates are still now considered as not that harmful compared to the IV. So what happened in bisphosphonates basically, the osteoclastic activity stopped. That's what the bisphosphonates make, will function on the bone tissues. So there won't be any osteoblast formation. The bones will become very brittle. So one patient was followed up for around 16 to 18 years with the bisphosphonates. Orally, didn't have much difference, but what happened is once she stopped taking bisphosphonates, then there was a severe bone, fractures and implants were lost. So that study contraindicated this. So still, at this, my understanding goes that oral bisphosphonates at a lower dose shouldn't be a problem. At least if they're taking bisphosphonates and have implants, there shouldn't be any problem. But IV bisphosphonates who have active, treatment of bisphosphonates have just have, cancer very recently and taking active treatment, and such cases are definitely contraindicated.
Thank you.
If you have placed implant and taking oral bisphosphonates, for example, you have placed the implant and cancer has come later and they have started with the bisphosphonates, then I don't think so there's a big problem with that.
Right. The next question, I think Dr. Shiraz or was it Dr. Nadeem? One of them will go ahead. Please do, Dr.
My question is to both of you. When we do the cementation, or when we are trying to do the cementation, we do the trial for a PFM crown. What I have usually come across is since the metal and metal contact is very tight, and we do the trial with the crown and the abutment, implant abutment, it is very difficult to remove the crown. It becomes very difficult for us to remove the crown and then re-cement it. Suppose we have to place the crown on the abutment with metal, and we try to check the high points or anything. It becomes very difficult to remove. Is there any technique to know whether we can remove it easily and place it back easily?
Dr. Hilal wants to take up this, or should I answer?
See, metal to metal contacts becomes very intimate, and retention becomes more, so it's very difficult to retrieve. So option is you can use floss below it before you place it, so that you can easily pull it up with it. Otherwise, you have a crown remover with the tacks, which you can also place it and slowly pull it with it. Those are the two options wherein you can easily retrieve it. Other option is if you really feel it's very tight, then you might have to relieve the inner surface of the metal of the crown and then place it.
Okay, Dr. Shiraz, I want to just add. See, we have whenever do a prosthesis, especially about the fit and about the path of insertion of a prosthesis into a abutment, we have two things. One is active fit, one is passive fit. Any prosthesis ideally should be a passive fit. We want to put a crown and we should be able to remove it without any hassle. That's called passive fit. That's called passivity. That's a special property which we want in our prosthesis, any prosthesis. But when it's very tight, as you said, then it's active. There is some problem. So you need to identify the contact areas, the interferences. You need to identify there are different type of materials also available. You can put it under the crown and put it there and remove it and see where it is contacting more, and you can reduce it. You can reduce it yourself, or if you can't do it, then you can send it back to the lab and you can get it reduced. Always make sure your prosthesis should be passive. The fit should be very passive, not very active. So this is where the problem comes. So it's a basically when we come in the lab errors which happens in the lab or in the whole fabrications procedure, some errors will happen. This is a lab error, so which we can't help it. It happens in every case. So we have to get it corrected and do a get into passive mode and then cement it.
Right, we've got the next question from Dr. Khan. I'll just phrase the question for you. It says, a retraction cord should be placed when taking an impression? While you make
cord for implants, retraction cord is not required because we know that we have created a soft tissue profile already. So always remember, when we have a subgingival margin, in the soft tissue will never integrate with the metal surface of the abutment. So soft tissue, the bone will integrate with the implant, and maybe maximum a bit of with the crest of the implants. If it is a machine surface, still it will not integrate. If it's threaded, micro threaded surface, still soft tissue will integrate a bit with the implants. So we don't want to expose that integration. So unlike which we do it in the regular our PFM work, so we don't need actually any retraction cord or anything like that when we do the impressions.
I have a question. I'm Dr. Nadeem Ahmed. Dr. Fayaz, Dr. Hilal, mashallah, great to see you guys on one frame. And I think Dr. Hilal is lighting up today's day with that colorful t-shirt of yours, mashallah, orange color on the dull day. Okay, my question is for both of you. Now, since when we talk about implants equals metal. So are we looking towards any non-metal kind of implants in the coming future, which can, which has faster osseointegration into the bone, where metal takes a longer time? So any research or any papers or any new material which is advanced in implant industry?
Dr. Hilal wants to take up this.
Non-metal, I haven't heard of it. Latest what we have heard is about the implants are zirconia, but then again it's a metal. But non-metal, I haven't heard of it, which is going to come shortly. Maybe it may take some more time. But right now, I have heard of zirconia, which has been doing good in foreign countries, not in India right away.
Sorry, there's a continuity to Dr. Khan's question. I'm sorry to interfere. I've unmuted you, Dr. Khan. Can you ask the continuity of your question, please?
Assalamu alaikum, Dr. Fayaz. This is Dr. Rahim here. Great, very informative podcast webinar, and salam to everybody. See, the question was, since we've had a few cases who come up with a lot of food lodgement around the gingival region where the contour is not fitted in well post-implant placement with the crown. So I was thinking, in case there are few cases, yes, agreed, the gingiva should grow accordingly and live for 3 months. In case it does not, then do you feel we should actually put a retraction cord while taking impression so we get a better fit? And also suggestive, my question was, I'm sorry, it's not the same, but a different question. The parallelism of the implant. Now, does it play a very important role for stability, or you only search for a good bone support and you place implant by angulating it?
Yeah. Hello.
Yeah, Dr. Fayaz. Yeah, I'm done with the question here.
Yeah. Okay. I'll come to it. You're talking about the retraction cord, just to retract the free gingival soft tissue which has been formed. Yes, of course. See the soft tissue. If you want to retract a bit of soft tissue, if it is tight, yes. In such cases, maybe retraction cord might help, but I have not come across, or personally, I don't use the retraction cord because I don't have that kind of issues. But I think I've seen some articles where retraction cord is used, and if it displaces the soft tissue to record it, yes, definitely it's of useful. Then comes to your next question about the parallelism. See, parallelism. I think, are you asking me about the implants, tilted implants and things like that? See the soft tissue.
Yeah, but implants generally, no. I think you could angulate an abutment, but implant parallelism plays a very important role in the occlusion. I'm talking about stability of the implant in general during the occlusion.
Yeah. See, ideally, we want to put all the forces along the long axis of the implant. What happens if you have two unparalleled implant? The resultant force, and again it depends on if you want to splint it or not. If you don't splint it, it's a different issue. If you splint it, again the resultant force which goes between somewhere the total angulation somewhere between the medial of the two total angulation of the implants, which is not good. Ideally, we want to have a perfect parallelism so that we distribute the stresses equally. But if you tilt it one implant and keep it one implant straight, the implant which has been tilted will experience more biomechanical stresses, and there will be some angular bone loss where more stresses are generated just below the angle of the implant. So this is what we don't want to happen. So if you can keep the implant straight and keep the abutment straight and restore it, that's the best scenario. Otherwise, if you can angulate in some situation, we can angulate it, but to a very certain degree. We can see the angulated abutments which have come for around 18 degree, 20 degree, maximum 25 degree, and some companies give up to 30 degrees, but not more than that. In literature, it says more than 45 degree angulation is definitely a failure. So we shouldn't go for more than 45 degree biomechanically. But angulation of 5 degree, 10 degrees is still acceptable. It's of not much concern, I feel.
Jazakallah, yeah. Thank you, Dr. Fayaz. Thank you.
Right, Nadeem wants to ask a question.
Yeah, I was just coming back to the same question. Dr. Hilal answered the zirconia implants. That is what is heard now. I happened to see an article. There's a new implant in town, which is talk of the town now. Those implants have calcium silicate particles in that. Sorry, my knowledge in implants is quite poor. I'm just giving you a rough picture what I saw. It's a kind of a white color. It's not a ceramic implant. Let me put it across. It's a white color. It's a porous kind of implant. Immediately after the extraction, you put it into the socket, and that porous implant, takes all the blood inside, and the integration is much faster. That is what I happen to see across. Just correct me, what I saw was right or wrong, or am I missing something on this?
Yeah, Dr. Nadeem, I think what you have read may be true, but I haven't come across those things. But if I get back, I will just go through it, and if I find it authentic, I'll get back to you and see it.
Yeah, I'm just going to ask somebody who's called Galaxy Note 10 Plus. They have a question to ask, so please. Right, I'll put forward the question. The Fayaz, the question is, in single tooth restoration with implant, you said something about implant protective occlusion versus mutually protective occlusion. How will you achieve this in a single tooth restoration? How easy it is to achieve different malocclusion cases?
Yeah. See, there are different concepts of occlusion. Again, when it comes to full mouth rehab, there are different concepts. For individual teeth, there are different concepts. So Mish initially, he proposed a scheme of occlusion called implant protective occlusion, which is nothing but a lingualized occlusion, which it's also a scheme of occlusion where in the lingualized occlusion, we want a point contact, a cusp to a central fossa. So upper palatal cusp will touch the central fossa of the lower lower molar tooth. So this is about the lingual cusp will touch the central fossa of the opposing tooth. That's how it is, and the other cusp will not touch. But if you are doing a single crown, yes, definitely a single point of contact or 2-point contact. That's all we want to, we look into it, and they'll work well. Mutually protective occlusion is the other scheme of occlusion where we give a contact on a particular tooth, but also we check the contact on the other teeth also during the function, during the lateral excursion. When you move the mandible protrusive or on the lateral side, other teeth should not, get into a premature stage or uneven contacts because of this restoration. That's called mutually protective occlusion. So, for example, you give a occlusion and you move it a little forward, then you see the anterior teeth are biting, and still you see your implant crown touching your upper molar. That's not a right occlusion. So you need to relieve the occlusion in that area. If there is any prematurity, you need to take it out. So that is mutually protective occlusion. There are different occlusal schemes. So we can discuss a lot on occlusal schemes. if best thing is, if you don't know anything about the occlusion, then there is something called monoplane occlusion, where we don't have any planes of occlusion. Where it's 0-degree occlusion or something like that. So occlusion is a separate big topic, but point contact is all we are looking at. So point contact with 30 microns gap is the occlusal scheme which we can follow for single tooth restorations.
Right, we've got another question by Dr. Tabassum. The lady asks, if we place zirconia abutment and zirconia crown on implant, will it affect retention of the crown? I think we've covered this, but I'd just like you to reiterate what you spoke.
No, actually it's a good idea to put if you're putting a zirconia crown, it's better to put a zirconia abutment, because especially in the anterior region, it will cover up the margins even if it is exposed. The only problem here is the screw, the prosthetic screw, which will connect the zirconia abutment to the implant. So that will be of metal. So as I was telling, metal to zirconia interface is the issue here. If stresses will get developed, and if the zirconia is thin, it will fracture easily, because zirconia is brittle compared to metal. So that's the link, that's the weakest link. So there is a theory that any prosthesis will break at the weakest link first. So the weakest link is here, the zirconia and the prosthetic screw intersection, or the zone, is the weakest link in this whole assembly. So if more stresses are there, it will break there. So we have to be very careful. But as I said, in the non-functional area, anterior area, it can be used where stresses are least. Again, issues will come in the posterior as we go, where functional stresses are more. So in the anterior region, definitely yes, it can be used safely.
Right. There's another question by Dr. Omar. I have heard of PEK implants. What is your take on this? Have you heard of? Actually, he's asking. I probably think he's asking, have you heard of PEK implants? I think Dr. Bilal and Dr. Fayaz, both of you can answer.
Is polyether ether ketone.
Polyether ether ketone. Okay. Please, can you give some insight about it?
We actually heard of prosthesis. We do prosthesis over the implants by using the PEK material. PEK implants as such, I haven't heard of it.
See, PEK prosthesis, or the PEK crowns, we call it, as they are intermediary or temporary crowns which we use. You're doing full mouth and you want to give occlusion till the implants heal. So what do? You use these materials which have less strength. So what will happen, even the stresses when they generated, this material will wear away and take out all the stresses. They don't transmit much of stresses to the implants which are healing. So the PEK abutments which are available made of polyether, commonly called as PEK abutments. So they're not implants. We don't have polyether implants as such.
No. But if I can just interject here, Dr. Fayaz.
Yeah.
There are a couple of PEK implants which have just introduced recently, I think in a couple of years back. They said they use reinforced materials and modifications for dental implant placement. These materials, the research is still not advanced as such to actually have, to conclude with conclusive or evidential concurrence, where they can say, okay, PEK implants are better than the titanium or metal implants. And also, Dr. Nadeem's question, what he wanted was actually, he wanted to ask about root form implants or the root analogs. They are the ceramic implants which are 3D printed and then they are placed immediately after the extractions. Have you guys heard about it?
Okay. Yeah, I think they take a image of the virtual image of the socket, and I have heard of it, but I don't have any long-term studies or the results about it. But I have heard of it, where they take a socket, a virtual image of the socket, and they 3D they mill the whatever the calcium substitute, and they're going to retrofit it into the socket and rebuild the tooth. That's what I think he was talking about, which Dr. Hilal answered it. Yeah, I have heard of it, but I don't have any definitive articles or long-term studies about it. I don't know, at least to my knowledge. I think that's how it is.
Okay. In fact, I saw a case, from a doctor from Germany doing this, and he does this case in and out. He says this particular implant, what Dr. Nair spoke, looks quite promising. It has, promising future compared to, titanium implants. So I think Dr. Nair has cleared my doubt. Thanks a lot, Dr. Nair. Jazakallah.
But the problem with the analog implants is more it's technique sensitive plus more of an armamentarium. So it is going to cost.
Right. Sorry, we'll have to probably conclude, but I have one last question before we go for both Dr. Fayaz and Dr. Hilal. The topic was for single tooth replacement. I just wanted to ask, what other options would you actually suggest if implants is not a very conducive proposition? What other single tooth replacements would you prefer other than implants?
See, the popular and quick option is fixed partial denture, which remains even popular for this day for a given short period of time or something like that. And yeah, the success rate is varies. Again, it's up to the understanding of the dentist, but both works very well. Personally, if you ask me, fixed partial denture works very well. It's been working for a very long time. They are promising. Only thing is we have to sacrifice the abutment teeth. We need to shape it a bit and things like that, and some problems later might come or might not come. But definitely implants, in an ideal situation, at least as clinicians, if there is a good ideal condition where there's a good amount of bone and good abutment teeth are there, then definitely I feel personally we should go for implants, and we should not we should discourage going for the fixed partial denture. If the abutment teeth have some problems like endodontic treatment or something like that, we should go for it. If you have any other issues, definitely really we do a cast partial denture, or at least do a small flexible partial denture, which can be done for a time being if the patient can't afford it or some other problem and you want to maintain the space. Just don't leave it like that. At least do a small flexible partial denture, which can be used, and at least maintain the space, and later it can be taken up. So a lot of people who come to us, especially if they have economic constraints, who can't afford it but wish to go for a better treatment, sometimes we give them small partial dentures like these flexible things, and we leave it for 1 or 2 years. Definitely they'll come back to you, and you can go for the treatment like this. We have a lot of patients we have converted from removable prostheses to the fixed restorations. So patients are also very well informed nowadays. They read a lot and they come to us. So try and see the situation, and try and give a best honest opinion, and try and do it. So I believe once the case comes, just do the treatment and finish it. It's not like that. We need to follow it up, whatever treatment we do it. So slowly start converting cases. So betterment of life, improving their quality of life is the final goal for any treatment approach. Hope I answered Dr. Ali.
Fine. I'll just add one more point on that. I'll just add up one more point.
Please,
you can use, if it is economical and if you want to use it for anterior also, you can use fiber reinforced composite bridges or fiber reinforced onlay bridges, which is composite reinforced.
That was one of the questions actually put forward by Dr. Sharif, Dr. Khurat Sharif. Please, if you could give us a brief.
Brief is, see, suppose you have an abutments, both are decayed or partially decayed with DO or MO on either side. You can always create an onlay preparation with 15 to 20 degrees of angulation, and then go for the impression and do a onlay composite reinforced bridges. But the success rate of this is not on a long term. So this can be used for some time, maybe for a few years. You can use this, and even for anterior where the patient is young, you can always use these kind of prostheses for the patients where their pulp horns are high.
Brilliant. Thank you. We conclude with one last question. Does Dr. Basha, Asim Basha has asked, does hormonal replacement therapy have effect on implants, HRT medications? Does it have any influence on implants, success and failure? Dr. Hilal can take Sorry, either of you.
Yeah, Dr. Hilal speaking, or should I speak?
No, you speak first.
See, any hormonal therapy which affects the bone definitely affects the implants. So especially during the growing stages, when growth is happening and things like that, definitely it will be affect. Another, there is a big debate which can happen on implants when we place during the growth of the jaws, especially in the pedo patients. Again, hormonal therapy, if you are putting any hormone, any hormone which causes bone changes, definitely will have effect on the implant. But I don't think so as such. Hormones which we are giving, hormones which given for different type of problems or different situations, need to analyze each hormone, what kind of therapy and things like that, and again the dose and the situation and things like that. Any bone changes causing hormones will have definite effect on implants too.
Well, thank you very much. I hope this was a very educative session, and hoping to continue further. But thank you to all the panel members, the speaker, the core group, and all our brilliant participants from GDP. I will be concluding the meeting because we are time restrained. If you need to ask any more questions, please put it forward on the group, and we'll be able to take further questions and answers there. But thank you very much. Jazakallah khair for all of you to attend today, and have a lovely evening. Bye-bye.